Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. I hope you're all enjoying or at least being able to survive this heat. We've had several days of over 100 degrees here in Southern California. We're a little worried about some more wildfires, but hopefully that won't take place. And so actually being in a nice cool office right now, I'm pretty happy about that. Let's go ahead and figure out what's today's hot topic. Well, Medicare has been putting out finally some MedLearn Matters articles. They've been putting out some alerts, and we have some MLN Connect newsletters. And one came up from August 7th that I really wanted to go over because they're really looking at evaluation and management services from a claims denial standpoint. And the information said that in 2023, the improper payment rate for E&M codes was 10.7%, with a projected improper payment amount of $3.7 billion. And they go into, preventing claim denials and understanding, what you need to do to not get denied yourself or have money clawed back. So what I found interesting is they're talking about medical record documentation, how it applies or links to not just the 2021 guidelines that we knew were new. When I say new, we're new. I'm saying KNEW new, we're NEW new. But then they really focused on the 2023, which was the update to the 2021 that focused more on hospital. And we know that there's been some hospital issues, especially since they did the ridiculous thing of combining observation codes with the inpatient hospital. We know that's a problem because observation is a place of service outpatient 22 and inpatient hospital is place of service 21. And obviously those lines can be crossed, and there's also payment considerations when it's outpatient versus inpatient. So I'm referring the MLN compliance newsletter 48-244-56, and it's August 7th, 2024, in case you haven't seen it yet. But I wanted to go over a couple of the things that was discussed just to kind of get back to basics. And it's interesting because a lot of the information really kind of almost goes back to the old guidelines or just guidelines in general. They talk about, E&M services. The nature and amount of work and documentation does vary by type of service, place of service, and the patient's status. But they said in all settings, the variable circumstances in providing E&M services have certain documentation characteristics that apply to everything. So first of all, it has to be complete and legible. Well, you think with medical records that are all electronic now, legibility isn't an issue. Well, it is. We're still seeing doctors writing on face sheets and thinking that's legible, or quickly pulling out their pen and scribbling in the patient's chart at the hospital, and we can't read it. So it talks about documenting each patient encounter with the reason for their encounter and relevant history. Even though we don't use history and exam to score, to level the code, we still use it for medical necessity. So to make sure that you even have a right to report a code, an E&M code, you still have to have the reason for their encounter and relevant history. You still have to have physical exam findings pertinent to the reasons that they're being seen, any earlier diagnostic test results that relate to today's visit, an assessment, clinical impression, or diagnosis. What did you find from these things? A rationale for ordering diagnostic and other ancillary services, a plan for care. And when you say PRN, that's patient return is needed. Your risk just went right down the drain. So I'm not saying you can't say that. I'm saying that for those of the providers out there that are trying to report level 5 and level 4 services, and they say PRN, even with an antibiotic where a patient's one and done or done after 7 days with a Z-Pak, I don't see the risk there. And then the date of service and legible identity of the observer. You still have to have a signed note or a closed out note, electronic signature, whatever. You have to make the patient's past and present diagnoses accessible to the treating or consulting physician. So even if it's archived, they need to have a way to access it. If there's any health risk factors, again, that affect today's or impact today's visit, any changes in treatment, and document the patient's updated diagnoses. We're still not seeing that. And then I don't like to see CPT or ICD-10 codes in the note. And there's nothing saying you can't put them in there, but a lot of times they're wrong. And I'm still seeing ICD-9 codes. Oh my gosh, you guys, we're 10 years out of that. Let's stop doing that in the documentation. But you have to reflect that the documentation does support the current active status of what diagnosis codes that you're putting in there. You have to be careful about, medical necessity is the main criteria for payments beside the requirement for individual CPT codes. I always get, providers saying, well, if I code CHF, does that make it, more money? I'm like, where are you getting this from? Are you talking about hierarchy codes, HGCs for your bonus of active codes that you're having to manage? Yeah, it has nothing to do with that. If you're not actively treating it today, you still have to show why you're even seeing the patient. It's not medically necessary or right to bill a higher level of service when it warrants a lower level. But also, I'm seeing a lot of undercoding. Be really careful about this. This is something that my good friend Stephanie Allard and I have been talking about lately because we both do quite a bit of auditing projects. And we're seeing that doctors thinking that they can get paid faster billing level 3s when it's actually a level 4 or higher. One thing that is making me a little crazy are those practices that have that primary care exception rule where the resident can see the patient, but only for level 2s or 3s if the doctor is not physically present. It doesn't mean that they still don't have to be in direct supervision, somewhere around that's accessible, but they, in the same office or same area, but they don't have to be face-to-face with the patient. If they're billing higher than level 3, so level 4 or 5, they actually have to be with the resident and right there, personal supervision. What I'm finding is that the doctor says, well, I can't be there, so just go ahead and report it as a level 3. Then we look at the actual note. The patient is of moderate complexity, and they're undercoding just to get money, and that's almost as worse as overcoding. And then I'm seeing doctors who are seeing patients in a consult billing the 99221 code, which is the initial hospital inpatient or observation. And I'm seeing things like sepsis and patients coming in with, toxic effects of chemotherapy, and now they've got renal failure or they've got new problems that are, high risk. And I'm just like, where are you getting this level 1? So medical necessity of, can't bill the higher level if it's lower. It also goes in the opposite direction when you're trying to bill a lower level just to get paid quicker. That falls under the False Claim Act. So be very careful with that, because I'm seeing more and more undercoding almost to manipulate the documentation, or I should say manipulate the process. Documentation is what it is, and you can't hold back on it if the patient truly is high risk or moderate and then code a lower level just because you're like, well, I don't want to flag anything. You're not going to if it's appropriate. If it's medically necessary, remember that is the primary criterion for payment, in addition to the specific requirements for each E&M service. So I know we always see that, it's inappropriate to bill for a higher level when a lower level is warranted. It's also inappropriate to bill for a lower level when a higher level is warranted. So I would really hope that we don't see that, even though I am seeing that quite a bit. But, talking about things that are not, or things that are, I guess, targeting or sparking some of these problems with E&M, they also go into some compliance tips. They said, other E&M visits that include hospital, inpatient, observation, ER, nursing facility, etc., they want to make sure that you understand that medical necessity isn't just about time. It's about what you did. We don't use the history and exam to decide the level, but there is a requirement, and this comes right from the CMS website, quote, there is a requirement for proper medical history or exam or both, depending on the patient. I know we see sometimes or, I hate that. And also you have to be careful when a doctor says something about, well, I saw the patient for greater than 10 minutes. No. We don't say, greater than, less than. We say exact time. The time is really important because it says you have to give either the substantive portion or the total time. Everywhere it says the total time if you're using time to level your visits. So when you don't put that total time in there, it looks like you don't care. And the other thing I wanted to make clear too is, remember, we used to always say, and I say we, consultants like myself and auditors and whatever, we used to always say, this is a legal document, and it still is. And, attorneys may see it, defense people, prosecutors, insurance payers, but patients have a right to their records now, and you have to give it to them within 30 days. And I've seen behavioral health claims, I've seen records where the patient says, what is this? Where it says the patient may experience this, or we spent, an estimated amount of time, or this may help. The patients want not just absolutes, but specifics. It doesn't have to be absolute. Medicine isn't like that. We don't know 100% of anything. But you should know as a provider if this will benefit this patient or not. And if it doesn't, or it does, again, related specifically to that patient, that should be part of your medical record. So the patient is going to want to see information relevant to their encounter, not the generics, not the wording in the CPT book. That is just outlining directions. That would be like, taking a map, trying to get, let's say, to a restaurant, and instead of, giving a narrative on what you see as you go, you basically just give the street names, that's in the map. Well, we know how to read a book. We don't know how to read a patient. We have to understand the patient, and every patient's different. Now, you may have some similarities. You may have, some smart phrases that do apply to this patient and that patient, but then you really have to tie in the thought process of what you're doing for this patient, and never forget your plan of care. Assessment, plan, and risk, that's the third element of the E&M. We have our problems addressed, we have the data, and then we have the assessment, risk, and what you're going to do. What's the management? What's the plan? And did the patient agree to it, not agree to it? Are they understanding of it? And how does that tie into how you move forward? So I wanted to bring that up today just because obviously we've got, a new administration, a new administrator for Medicare with Dr. Oz, new HHS secretary with Secretary Kennedy, and they are on top of this. I've never seen two people, and actually his whole administration for healthcare, really, involved in patient care and making things better. And so whether you like it or not, I really like the way, that what they're headed and what they're trying to do for patients. There's also some new updates when it comes to the fee schedule. I will outline those coming up soon, just talking about a little bit about, telehealth and things like that. But I wanted to get this out today because E&M codes, those are low-hanging fruit. And you don't want to invite risk if you don't have to. So make sure that now that we're in the summer, a lot of the doctors are taking time off, and you create some educational material. So when they get back, say, hey, we're going into the fourth quarter really strong. So then for 2026, we know exactly what we're doing. And I also will have some on-demand webinars. I have them now, so you can always access those if you're a little lost on what to do. I also a shout out, we've had a lot of new membership clients that have joined this month, so it's really nice to have you. St. John's Health, HFCCA, CalMed, Zen Medical, Carolina East, Tennessee Orthopedic. Really good to have everyone. And we can't wait to service you in our membership service. So for those of you who are wondering what that is, we have something called the Coding Corner membership. It's been around now for 31 years, and it's a yearly membership where you can get coding, billing, and compliance questions within 24 hours answered via email, and it's a yearly membership. And if you're an executive member, you also get an Ask Me Anything quarterly Zoom call, and we have one coming up in a couple weeks. And so I really hope that if you're needing something like that, that you join us and be part of our membership. We usually have consistently, probably 50 to 80 members. Some come and go. I've had a couple that have been with me for over 20 years, and some have gone and come back. So it's really nice to have everyone and we're all over the country. So everyone's all over the country. So it's nice to have those of you that continue to support that membership, and I get to hear from you. So it's really nice. All right, everyone, make it a great rest of your week. Thanks for checking in. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.